Yeah, good morning, everyone. Hope you're all doing okay today. Hopefully, you guys can hear me. Morning, Tehran. Hope the exam did not leave you too shell-shocked. Fantastic. I think I have a few drive-by streamers. I think I've had a few times in this lecture I've had like 31 viewers, and I'm like, who's that extra one? I don't know. Could be my other students, could be former students, random strangers, could be anyone. Who could say? Yes, thank you for joining me today. Appreciate it. Started here in about a minute or so. Of course, in regards to the exam, I have to look at all the stats and all of that before I can go through and is there any givebacks or anything like that. So we shall see. But hopefully, thought it was, a fair assessment of your knowledge on the stuff we covered. Hopefully, but I'll post an announcement about any high miss questions and stuff after the fact. And then if you have questions, you can feel free to reach out to me if you like, which you're always able to do. No harm in that. All right, so I believe we left off here. I think we got through the initial discussion of Parkinson's pathophys. Is that correct? Can anyone tell me if that is not the case? Or does that seem correct? I think I finished the epilepsy stuff and then started going into Parkinson's, but I did not get to the drugs yet. I shouldn't be relying on you guys to know where I left off, but that's okay. Okay, good. Thank you, Selena. I appreciate that. Okay, so let's get into the drugs here. So we were talking about Parkinson's basically being a deficiency in dopamine, right? If you're missing dopamine, it's harder to initiate movements. You also have that increase in acetylcholine as a result of drops in dopamine that cause like the resting tremor that occurs there. So those are kind of the main things you're going to see. In terms of management, we'll see here that there's a couple of drugs we can use for what we deem as neuroprotection, which is designed to sort of slow down the progression of disease. How ultimately effective those are at that is probably questionable, but there's some evidence to show that. And then in terms of symptomatic management, that's where most of our drugs are going to come into play here. And so we'll look at some of these different options and how they kind of help out our patients with Parkinson's. So first off, we'll see that the dopamine agonists are going to be drugs that basically just replace the dopamine that they're missing. It just, is not a substitute for dopamine. They just activate the same receptors, right? And you can see that several patients will have a period of time before they require therapy with levodopa. Levodopa is going to be basically like definitive therapy here, but once they get on that, they're kind of stuck on it until that drug wears off, and there's really nothing much else that they can use at that point. So the goal is to prevent them from needing levodopa for as long as possible, so that way they can receive the benefits of that drug as long as they can, basically. And so you'll find here that by initiating these dopamine agonists, you can sort of also delay when they start to develop some more of the side effects that you're going to see with levodopa here in just a little bit. The monoamine oxidase B inhibitors. Monoamine oxidase is, again, one of those enzymes that metabolizes dopamine along with some other catecholamines. We'll get into monoamine oxidase inhibitors more so in the behavioral section coming up next. But here we're focusing on the B isoenzyme instead of the A. And so we're focusing on A, and this is helping to metabolize dopamine. So if I inhibit that, if I stop that process, then hopefully I'll have more dopamine floating around. And again, if you look at this, one of the big features here is that by metabolizing dopamine, you produce things like hydrogen peroxide and reactive oxygen species, which can cause a lot of oxidative damage to those nerves, right? They can damage proteins in the cells themselves to where they can trigger apoptosis. So by stopping this process or by slowing it down, you're hopefully going to be getting less of these reactive oxygen species and preserve the neurons for longer. That would be ideal in those cases. So from the monoamine oxidase B inhibitor category, we have two main drugs here. We have selegiline, and then we have rasagiline. Both of these basically can be used early on for more mild to moderate cases of Parkinson's, and again, to help delay the need for levodopa, okay? Interestingly enough, selegiline actually gets metabolized into L-methamphetamine and L-amphetamine, and so this will actually show up on a urine drug screen as amphetamines, right? So just like if you're taking ADHD drugs, which are primarily amphetamine based, you could see a Parkinson's patient show positive for amphetamines and think that maybe they're using illicit substances when in fact they just have selegiline on board. But as you might imagine, having amphetamine derivatives, if you could imagine someone who is taking amphetamines, what that looks like, they're usually very, more energetic, so to speak. They're going to have, it's a stimulant, right? So they're going to have increased blood pressure. They're going to have agitation. They can have hallucinations. A lot of that same stuff applies here, just more to a mild degree. So you can see sleep disturbances and things like that. A big thing you're going to see here by affecting dopamine is a lot of orthostatic hypotension. And keep in mind, these patients are already having bradykinesia to begin with and unsteady gait. So if you have this on top of the fact they have that gait instability, it's pretty easy to see how they could be at risk for falls and potential fractures, right? Rasagiline does not have any amphetamine derivatives, so it probably has fewer adverse effects than selegiline, but maybe not quite as effective. So kind of take the good with the bad in that case there. Both do present a risk for something called serotonin syndrome. Monoamine oxidase B is also responsible for metabolizing serotonin. And if you have too much serotonin, that can be a problem. But I'm going to get into that in the behavioral health section coming up, so I will save it for there. So you can use these as monotherapy for more mild cases of PD, as I mentioned, but there's a lot of meds you don't necessarily want to mix and match with these monoamine oxidase B inhibitors because they can increase your risk for things like that serotonin syndrome, increases in blood pressure, and things like that. So as an example, we covered tramadol already. If you remember, tramadol inhibits the reuptake of norepinephrine and serotonin. That's why it was somewhat effective for neuropathic pain. In this case here, if you have this in conjunction with something that's inhibiting the metabolism of norepi and serotonin, you can see how those elevated levels can lead to a lot of side effects. So this is why you want to be careful when mix and matching these drugs here. So lots of other things can affect this, some of which I will get into in the behavioral health section coming up next. I know I'm kind of alluding to a lot of that, but there's a lot of crossover here in terms of like neurotransmitters and things like that I will get into in just a little bit. There's also a lot of foods you want to avoid when using monoamine oxidase inhibitors, and this is something that, again, will come up in the next section. But basically, a precursor to things like dopamine and norepi and serotonin, a lot of your catecholamines are going to be this product called tyramine. Tyramine is something you can find in several types of foods, and if you have a lot of that coming in through your diet, that is, getting converted into these catecholamines like norepi and dopamine, and you're inhibiting their metabolism, the levels can just get way too high. You have too much supply and too little metabolism, and so that can lead to a lot of toxicity. So that's why they say if you're taking a monoamine oxidase B inhibitor to avoid these foods. And so what are those foods, the high tyramine containing foods? I like to think of them as I call them the bougie foods. So these are like things you'd eat at a fancy dinner party, assuming we ever get to have parties again. But things like aged meats and aged cheeses are going to be a big one here. Things like fava beans, red wine tends to have a lot of this, sauerkraut. Maybe if you're at a German fancy party, I don't know. These are things that have high amounts of tyramine that you would not want to consume in conjunction with taking a monoamine oxidase B inhibitor. There's lots of things they can have, right? So they can have veggies, they can have fresh fish and meats, they can have beer and bottled beer and or canned beer instead of red wine. Any of that's totally fine. So it's good to identify things that they should not have to make sure they don't run into this problem of having way too much catecholamine synthesis happening here. Other things we can do for symptomatic management early on includes our anticholinergics. This is basically blocking that increase in acetylcholine that we get when patients have a deficiency of dopamine, right? And so this is going to be good for patients with tremor and they have minimal hypokinesia. So if their primary complaint is just tremor, then you can use an anticholinergic drug, and that's going to be good here. The downside, though, is what we've seen with other anticholinergic drugs, like a lot of our first-generation antihistamines, is that they can cause, changes in mental status for elderly patients. They can worsen their, if they have dementia, they can worsen that. They can cause them to be sleepy, things like that. So for older patients, you may want to avoid some of these anticholinergics just because, it's going to have a negative effect on their mentation. They're going to have other adverse effects associated with this too, due to the anti-muscarinic actions of the drug. So things like dry mouth and constipation and all of that you should be familiar with our talks of other anticholinergic drugs there. Also, you don't want to have patients going off of this cold turkey. You generally want to titrate them down so you don't get any kind of rebound tremor associated with that. 3 big ones you're going to see used for this purpose in particular are going to be benztropine, trihexyphenidyl, and then diphenhydramine. Right, so we've seen diphenhydramine before for sure. Any of these can be used for this indication here, and this would be just something chronically they would take for a while until their symptoms of hypokinesia sort of got worse, and then at that point we need to switch therapy to something else. So they have their younger patients, I'd say less than 75. If they have minimal hypokinesia with just resting tremor, these are good drugs for that. All right. Next, we have amantadine or Simitril. This is a drug where we don't have necessarily the full mechanism down here, but it's thought to have sort of amphetamine-like actions where it actually helps to increase release of dopamine. It also has some anticholinergic actions and some ability to block glutamate. How clinically useful that is, I'm not really sure. But we can say here that this is good for more mild cases of PD, either as, by itself or maybe as an add-on to something else. So maybe if they're on benztropine, you could add this on to that. They're starting to develop more hypokinesic little symptoms there. Just be aware that you can see some mental status changes with this. You can see things like anxiety and insomnia, which makes sense. It's sort of acting like an amphetamine, and you can see some anticholinergic effects. This is good for like earlier cases, but you will develop tolerance to it over time, and it may not really be that effective in the long run. So again, this is not like an always used medication, but it could be a useful add-on. Then we have our dopamine agonists. These, again, can be utilized initially to try to, increase the time until we need to put a patient on levodopa. These can activate all the dopamine receptors that we have here, and they will be divvied up into what we call ergot and non-ergot derivatives here. So I'll show you what those look like in just a moment. And they can be the first drug that a patient goes on when diagnosed with Parkinson's. So you can either kind of do this or a monoamine oxidase B inhibitor, and that would be perfectly fine, right? If they're having those hypokinesic symptoms. And again, you can find that, they can hold off several years until the patient needs levodopa, which could be useful. That's extra time that the levodopa can be used in that patient there. Keep in mind, though, that because it is a dopamine agonist, if you're using it with anything else that can increase the action of dopamine, like levodopa, because levodopa eventually gets converted into dopamine, that you'd want to decrease that dose. So that'd just be something to note there. And certainly, again, a lot of these side effects look very similar to one another, like hallucinations, confusion, insomnia, orthostatic hypotension, very similar side effects. So again, they're kind of all doing the same thing because they're activating dopamine in the end here, right? Ergots themselves can be a bit of an issue in the long term. Sometimes you can see some valve issues. You can see things like retroperitoneal fibrosis. So these would be things you'd be monitoring for. Certainly if a patient had history of valve disease, maybe that would be something that you'd want to avoid perhaps, right? So when I say ergot derivatives, ergots basically means it comes from the ergot fungus. And so this is an infected piece of rye that has an ergot fungus on this. And so just to give you some historical context, if you ever hear that, and I use this story because it reminds me of some of the side effects that you're going to see, and this will come up when we talk about migraines and some other things here too. But if you've never heard the story, there's this this is back like in the wee olden times, back when there were still peasants and working the fields and stuff. But there was this affliction they could have called Saint Anthony's fire, where they would be unknowingly eating infected rye with this ergot, and it would cause, because these ergot derivatives can cause vasoconstriction. You'll typically see hypertension associated with these drugs. It was causing severe vasoconstriction, especially at like the terminal ends of arteries. So things like the fingers and the toes were particularly affected. And when you cause that vasoconstriction, it feels very hot. It feels very painful, and eventually can become gangrenous and may need to be amputated, as an example. And so back then, there wasn't a whole lot of science to say, oh, well, obviously it's this infected rye that we're having here. Everything really came down to, religious afflictions. It was either, a curse sent down by the gods, or it was the devil doing it, or something like that. So they said, okay, well, we need to get rid of this. Let's go on a pilgrimage and go pray at St. Anthony's Cathedral. So they said, okay, let's go do that. And so what was interesting is that as they were moving away from the infected rye, and by the time they got to the cathedral, they prayed, all of a sudden the ergots are gone and they're better. So they said, okay, well, obviously this must be divine intervention. God made everything better, right? And so it wasn't until later that we were able to get the context to say, okay, well, obviously it was this infected rye that was really the issue here. So that's why they call it St. Anthony's fire, associated where they went to pray in order to get rid of this this affliction. So I always thought it was kind of an interesting story, but also shows some of the side effects you can get from these meds here. Pretty cool stuff, I think. There's also going to, and so the one here we're going to find is going to be bromocriptine. That's the primary ergot derivative here. When we get into talking about migraines, we're going to see some other ergot derivatives as well. So that will still apply to that point. We have the non-ergots, and so this includes several drugs like pramixapol, ropinirole, rotigotine, and then another product called apomorphine. Some of these are nice because they have like transdermal products available, so that can be good if they have, associated memory impairment or Alzheimer's on top of Parkinson's, so that's handy. And then apomorphine is something that is not available orally. Typically, it's usually given via sub-Q injection. This is something I mentioned before that you could actually use as diagnosis or as a diagnostic tool. So if you had someone you suspected having Parkinson's based off of hypokinesia and shuffling gait and things like that, if you gave them this, then that would fix their symptoms, right? That would improve their symptoms, and you could say, yeah, it's probably Parkinson's. This is actually a derivative of morphine, but it lacks any of the opioid qualities. So that's why it's called apomorphine. It's a derivative, but you don't have any opioid effects, but it does activate dopamine. So that's the handy thing that we use there. And again, side effects are going to be pretty similar to all of those. So like, the orthostatic hypotension, the agitation, insomnia, things like that, all can be seen there. So definitively speaking, in terms of Parkinson's, what we can finally put the patients on are a combination drug of levodopa and carbidopa. Levodopa itself is that precursor to dopamine that we saw back on that slide of look at the generation and degradation of dopamine. This drug is able to cross the blood-brain barrier. It gets into the neurons, can be converted over into dopamine, and then can fix a lot of the symptoms the patients are experiencing, whether it be the resting tremor, whether it be the hypokinesia. All that can be corrected with this drug here. So very, very effective at what it does. When we were talking about that Awakenings movie last time, this is the drug that they were giving, basically, was levodopa. It was waking these patients up, basically. Now, levodopa itself has a hard time getting to the brain because it can be metabolized by peripheral enzymes. And so in order to make sure that it's able to get to where it needs to work, we combine it with something called carbidopa. And carbidopa basically inhibits this this LAD enzyme, this L-amino acid decarboxylase, I believe is the full name. This is going to keep it from being metabolized in the periphery and allows it to get into the CNS where it can work. And the carbidopa doesn't cross over, so it doesn't do anything in the CNS. And so you're able to give lower doses of levodopa, and that helps decrease some of the side effects, things like the orthostatic hypotension, because that's a peripheral effect acting on dopamine receptors in the on the vessels and whatnot. So you're going to find that this is used orally, and it can have some issues because it's, an amino acid derivative. It needs to be absorbed through amino acid transporters, and unfortunately, you can find some competition there. So if you were to eat, say, a big juicy steak or something with a lot of amino acids, something protein-based, you can find that if you took this with levodopa, it would compete for the same binding sites and can prevent it from being absorbed. So sometimes you have to think about, well, if the drug isn't working, why is that? Some of it could be because it's not getting absorbed very well. So one of the things that we'll tell patients as well, if it's not working very well, if it's taking too long to kick in, we'll actually tell them, well, move your proteins around. So that way, maybe in the morning, you take your levodopa, but you skip the eggs and the bacon, and then you can have your proteins later on in the day, right? That's one way you can try to get around that competition and absorption. I remember going to like an actual there was like a Parkinson's support group that some of our students were giving a talk to, and it was just really fascinating listening to some of the patients there and talking about their experiences. And he was like really lamenting that he couldn't have his eggs in the morning anymore. He was really it's little things that you really take pleasures in, and he wasn't able to do that anymore because he needed his levodopa in the morning. He needed it to work then, otherwise he's going to be really non-functional for most of the day. So pretty interesting thing in terms of dietary interactions here. Anyway, so you can see that by giving it with something like carbidopa, we can extend the half-life. You'll see also that the half-life is fairly short, so that's why you'll see a lot of like continuous release products or CR products, and that's in order to allow it to be absorbed sort of throughout the day instead of just all getting a big bolus dose all at once there. I'll talk about entacapone in a little bit, but that's another drug that's able to inhibit metabolism of levodopa and prevent it from being degraded too early. So you'll find that these drugs will work great. They talk about the levodopa honeymoon for these patients, that when they get started on it, they feel wonderful, feel much better. Most of their symptoms are being managed very well at the start of this. However, it's only going to be so long as you're able to convert the levodopa into dopamine. And so if you lose all those neurons, you can't convert it over, then you're kind of out of luck at that point, right? And so that's why you could use it initially, but you'll find that it's going to become less effective over time. So that's why we try to use other things first, like the dopamine agonists, like the monoamine oxidase B inhibitors, and that will help us to, try to save the levodopa for as long as possible, right? So, but eventually all patients are going to require this. It's just going to be something that happens there. But again, the side effects are exactly the same as what you're going to see with the dopamine agonists, like the hypotension, somnolence, insomnia. All that's very similar. So again, it's pretty easy to memorize the side effects for these drugs here because they're all really the same. So Sinemet is the common brand name you're going to see for the combination of carbidopa, levodopa. Typically, you're titrating and adjusting the dose of levodopa that they're getting throughout the day. You can see there's like a max of carbidopa that you can get, but you can just keep going up on the levodopa dose. That's kind of the big difference there. And think about dosage forms too. It's nice that there's a continuous release product. This is good for patients who may take it, say, in the morning, but then by the afternoon it's starting to wear off, right? That way they can go ahead and have a continuous release product to get it working throughout or longer throughout the day. Or if you have a patient with Parkinson's who all of a sudden has dysphagia as their disease develops, right? So again, initiating those coordinated movements, swallowing is a really complicated set of movements to occur there. So dysphagia is unfortunately common in these patients as they get more and more progressive. We have things like oral disintegrating tablets. That way they can just put it in their mouth, let it dissolve. They don't have to worry about swallowing it because that can be a big challenge. Sometimes these patients will have to have things like G-tubes in place and things because they just can't swallow anymore. They're such a big aspiration risk that they can't take anything PO anymore. So again, it's difficult to say what's the initial best choice here. Part of the problem with levodopa is that it gets metabolized just like dopamine does. So we were looking at the monoamine oxidase B inhibitors and how those help to prevent oxidative damage. Well, in this case here, levodopa may hasten that because you're making more dopamine, so more of it's being metabolized, thus more free radicals. So that's one of the problems there. I think that's why we try to hold off on using it as long as we can. But we do know that it helps reduce things like mortality for these patients here. And again, if you can utilize a dopamine agonist or monoamine oxidase B inhibitor first in the short term, that's going to be beneficial. And then I'd say then switch over to levodopa. Another thing that we can do to try to extend the half-life of our levodopa is to use a COMT inhibitor. This is an enzyme called catecholamine O-methyltransferase, which basically metabolizes dopamine, metabolizes the L-dopa. So if you are able to inhibit that enzyme, levodopa sticks around for longer and more of it can be converted into dopamine. So that's very handy there. Note that you'd want to do things like reduce your levodopa dose initially by about 25% because, again, you're going to get an exaggerated effect out of it when adding this on. So you can drop the dose and then adjust as they can tolerate it. So you'll see that there. Don't use this with a monoamine oxidase inhibitor. You'll find that this gets way too much catecholamine toxicity because COMT is not just for dopamine, but affects things like norepi and other catecholamines as well. So I would definitely avoid that. And then, as in terms of side effects, it's really just more so potentiating the effects of levodopa. There's nothing really unique in and of itself. It just makes the patient more likely to have side effects from the levodopa because there's just more of it around, right? One thing that is unique to this particular drug, though, that we'll see with these is they can turn the urine sort of a brown orangish color, which again would be pretty disconcerting for patients that they were not expecting it. So that's again another reason. Anytime you change the color of someone's pee or poop, you should let them know beforehand, right? So we have two in this category, but really one that we're going to be using clinically. There was tolcapone, but there's a lot of hepatotoxicity with this, so I don't really see a ton of use with it. Instead, we use tacopone pretty commonly there. And in fact, there's even a triple combination drug here of tacopone, carbidopa, and levodopa all together, right? And make sure that levodopa is as effective as possible. So tacopone is probably the more common one you'll see used in these cases here. So let's kind of go through the treatment algorithm and how you manage these patients. Let's say we have a diagnosis. Someone has a question here. Someone said, due to the side effects being very similar, how would you like us to focus our studies on these drugs, MOAs and interactions? Just like you would for anything else, right? So if you're trying to categorize these drugs here, you can kind of just say, in general, Parkinson's drugs. What are the common side effects, right? And so you can say things like orthostatic hypotension, mental status changes, insomnia, hallucinations. You can just put all that into one box in terms of like common side effects of Parkinson's drugs, right? And then when you drill down into individual drug classes, that's where you can look for the unique stuff, right? So for instance, like, okay, remember like Acetylcholine gets converted into amphetamines, and that can show up on your drug screen. Or entacapone can change the urine in orange brownish color, right? So try to get like the general stuff at a higher order of level in terms of thinking of just Parkinson's drugs. And then as you drill down further into individual drug classes or drugs themselves, then you look for the unique stuff, right? So that hasn't really changed, and that should be sort of the paradigm of learning this stuff as you go through with any subject, not just Parkinson's, right? Or if you have a different way of organizing this stuff for your mind, that's okay. You can do it however works best for you, but that's how I kind of think about it. Anyway, so looking at their presence of symptoms and kind of what's going on here. So if they're having no significant impairment, you can consider starting them on something like rasagiline or selegiline, something to help, again, with the neuroprotective features there, right? If tremor is the primary thing they're running into and they're less than 65, I said 75 earlier, but it's probably closer to 65. That's kind of the elderly sort of cutoff there. You can consider an anticholinergic. Remember, if you go above 65, anticholinergics tend to kind of cause a lot of, mental status changes and CNS effects for elderly patients. It can like worsen dementia and stuff. Usually try to avoid it if at all possible. So you can consider anticholinergics here, but if you can't utilize these alternative drugs, then just go straight to the levodopa, carbidopa, right? That's generally going to be the mantra here. And again, if they are failing anticholinergic, then again, go to Sinemet right here. If their primary issue is bradykinesia or rigidity, again, if they're less than 65, go to the dopamine agonist. Bust out the bromocriptine or ropinirole. Any of those are fine. Greater than 65, again, you should probably go back to the Sinemet at that point. Okay. As we get into more postural instability or gait impairment, remember, physical therapy is super important for these patients. Again, it may not be easy for them. It may be difficult to get coverage from insurance, but it's going to help them make sure they keep muscles strong, make sure they can maintain more postural stability, and prevent a fall, hopefully, down the road from occurring there. Okay, so that's the general flow of things. And again, typically early on, you're going to see that patients will be managed well in monotherapy, and then as they progress, you'll be using multiple drugs together, maybe a dopamine agonist plus levodopa, or maybe a monoamine oxidase B inhibitor plus something else. But once they get on to levodopa, that's where they get that honeymoon phase. That's where things are, the symptoms are pretty well managed at that point there. As time goes on, you're going to be peeling back more and more drugs to where you just really have levodopa left by itself, with the carbidopa. But so that's the general flow of things. You'll start off on one drug. You may use multiple drugs at the same time. But once they're on levodopa, that's kind of the thing that they're going to be on for the rest of their lives, most likely. And then that's the thing they'll stay on towards the end here when all the other drugs have sort of lost efficacy or they're just causing too many side effects, things like that. And that's where we kind of get to the late stages where they start to lose more of those levodopa benefits. So things you want to look for, again, is looking at the drug administration time. So especially like timing around like protein. Not that they have to move proteins, but they're noticing that the drug is not working. then yeah, move the proteins to later into the day if they're going to be taking their Cinemat in the morning, right? A lot of these patients are older, so make sure that they're understanding their drug regimens and understanding how they're scheduling things, and make sure they have tools to help them become successful here. And then look for the side effects that they're experiencing. Look for adverse effects and all of those. Certainly non-adherence, you want to find out why they're non-adherent. It could be due to side effects, could be due to other things. So if you can identify that, you can hopefully maybe plan around it. And again, assess the quality of life. You can ask a patient, hey, how are you feeling today? And say, oh, I feel fine. You know, and maybe they're just being polite, right? But ask about like what they're able to do. Like, can they get up? Can they shower themselves? Can they cook? Can they, do the things that they want to do? And that will give you a better idea in terms of functionality of how well the drugs are working, right? So that's primarily it for Parkinson's. Unless you have any questions, I'll move on into the next section here, where we get to talk about Alzheimer's. Basically, with Alzheimer's, what we're finding is that we're having a loss of memory, typically due to lots of hippocampal and cortical neurons that are most often associated with like memory and cognition. And so, it starts off innocent enough with just some short-term memory loss, but then it can get much more complicated in terms of things like being able to plan out certain actions or being able to problem solve around things. And then eventually gets to identity, language, movements all become lost. And so again, it's a very progressive disease, very sad disease if you've ever seen it. I know I've had a few family members go through this, and really, really sad to see, basically their identity just vanish over time, Not to say that other things aren't sad, but this is one I have some experience with. Anyway, kind of what's happening here, and again, we don't have the full story in terms of the pathophysiology necessarily, but we know we're having degradation of these neurons. You can see things like these neurofibrillary tangles that form here. You can see these plaques that form. A lot of this is due to these cells dying and then the immune cells coming in to sort of attack that, and then causing inflammation that hurts other neurons in the surrounding area. So sort of the self-perpetuating sort of cycle here that happens, unfortunately. The main goals here are to try to treat the cognitive issues that they're going to be running into and try to preserve their function as long as they can. Oftentimes what you're going to find is as patients lose more and more function and they're less able to take care of themselves, and let's have someone at the home that's able to really provide good care, or they're able to get in-home care. This is oftentimes where they end up getting put into assisted living facilities and nursing homes and things like that. And generally speaking, people don't tend to do well in those places. You're around other people who may be sick. There's a lot of infections that can develop there. They may not be getting the best care depending on where they're at. So if you can keep them in their home for longer, that's generally going to be a good thing if at all possible. Again, there's no cure, but if we can do anything to try to manage their symptoms and maybe slow or reverse the disease, that would be good, but we don't have anything really definitive at this point, unfortunately. So as I mentioned, the main thing you're running out of are these cholinergic neurons. So with Parkinson's, we're running out of these dopaminergic neurons. Now we're losing cholinergic neurons. So we're going to see how we deal with that is going to be a little bit different here. So normally what's going to happen is that, let's say we had a presynaptic cholinergic neuron and then we have a postsynaptic neuron. Let's say this is in the hippocampus, which is responsible for a lot of memory. We'll see here that acetylcholine is going to be released out into the synapse where it can interact with the postsynaptic receptors, right? Normally what happens is acetylcholine gets broken down by a cholinesterase, and there's several varieties of cholinesterases that will then break it down into choline, where it can be reuptaken and then be reformed into acetylcholine to do its thing all over again. So if we're losing neurons up top here to release more acetylcholine, the question is, well, how do we get more acetylcholine in order to interact with these postsynaptic receptors? So there's a couple ways you could do that potentially. Maybe you could affect the reuptake, but the choline doesn't really do anything, so that's not going to really help you at all. That's not going to be the same as when we get into things like, the SSRIs for depression. So instead, what we can try to do is inhibit the breakdown of the acetylcholine in the first place. So by using a cholinesterase inhibitor, we're going to see that we can get more acetylcholine to interact with these receptors and thus get better function, hopefully better memory. And so you can see what this would look like in terms of normal brain, a healthy brain, how the acetylcholine gets broken down normally versus a brain with Alzheimer's. You're going to see lose some of these neurons, thus you have less acetylcholine to go around, and thus you get less function at those postsynaptic neurons. So again, this is what we're trying to do, is enhance acetylcholine action so it can interact more so with these receptors. So general things we want to consider is if we can have longer half-lives of these drugs, the better. Again, memory impairment is a primary thing we're seeing here. So you want patients to have drugs with easy regimens, like just taking them one time a day would be very beneficial, right? We also want them to have high specificity for cholinesterases that reside within the brain. You will find that we have cholinesterases all throughout the body. And if you start to target all of those ones throughout the body, you can run into a lot of side effects, which we'll talk about. And then obviously you want the drug to get to actual site of action, which is in the CNS. So it has to cross that blood-brain barrier there, right? And we'll talk about some modes of inhibition, like how reversible some of these enzymes are, and we'll see how that can have some roles to play in terms of its clinical actions. Now, the main toxicity you would see here has to do with their ability to affect those peripheral cholinesterase enzymes. And so I use a cholinergic mnemonic here called the dumbbells. Now, these are going to be more mild than if you were to see like true cholinergic toxicity due to, like, I don't know, a nerve gas attack or something like that. But these are the things I want you to know from this. So in this kind of will guide you in terms of what expected side effects you can see with these cholinesterase inhibitors. So the dumbbells. So starting out, like, think about the anticholinergic drugs we've already talked about. Remember, they dry you out. Remember, they cause mydriasis. Remember, they cause constipation and urinary retention. You're going to see all the opposite stuff here because you have too much acetylcholine action at the muscarinic receptors now. So the D in dumbbell stands for defecation. You can see diarrhea associated with this. U stands for urination. You'd expect to see maybe incontinence could be worsened if patients are already having this issue here. You'd see meiosis. The pupils should get smaller due to this. And then in the middle here is what I call the killer bees. These are unlikely to occur in patients taking simple drugs for Alzheimer's, but it's still good to know. Would be bradycardia, so it can slow down the heart rate because more acetylcholine on those vagal receptors, muscarinic receptors can slow down the heart rate. Bronchorrhea, again, you're developing more secretions. You're urinating more, you're having more defecations, you're getting more secretions in the lungs as well. So you can get bronchorrhea, and then bronchospasm can also happen as well. It can clamp down on those bronchioles. The E stands for emesis. Again, they're having basically fluids coming out of every end. L is for lacrimation, so again, tearing increases, and then salivation, having more spit production as a result of it just having more secretions. Okay, so those are the typical dumbbells when I think about in terms of cholinergic toxicity, and some of these things you would expect to see with drugs that maybe are affecting some of those peripheral cholinesterase enzymes. Okay. So ideally, the ones we're going to be using work mostly centrally. These are going to be better for more mild to moderate cases of Alzheimer's, and hopefully will help to improve memory and cognition. That'd be fantastic. However, they don't really do anything towards slowing down the neurodegeneration, right? So again, these are used for symptomatic management, but it's not going to slow anything down, unfortunately. So a couple of things here. So we're going to find that acetylcholinesterase is the predominant form that we're going to find in the brain here. There's different isoforms you're going to find, whether in the brain, the muscle, etc. We're mainly going to be focusing on the G1 variety here because that's the one primarily expressed up in the CNS here. But you can even find that butyrylcholinesterase can be responsible for some side effects. You can see here how it's abundant in the liver and the plasma, so that'd be responsible for a lot of peripheral effects here. So if we can avoid affecting butyrylcholinesterase and instead just affect that G1 isoform, that's going to be beneficial in order to avoid side effects, as we'll see. Someone said, for Alzheimer's, is it possible to give acetylcholine instead of inhibiting the breakdown of acetylcholine? Is it just not possible with a drug? Yeah, because the problem with acetylcholine, actually an interesting point, is that acetylcholinesterase is one of the fastest enzymes in the body. I mean, it's incredibly fast. So if I were to just give acetylcholine peripherally, even if I gave it as an injectable, it would never make it up to the CNS. It would just get degraded too quickly by peripheral cholinesterases. So instead, if we can try to use something specific to affect the enzymes up in the brain, then we can be more specific with our actions. And also, if I were to give acetylcholine peripherally and wait for it to cross the blood-brain barrier, you get a whole lot of those cholinergic symptoms. So the bradycardia, the defecation, all of that. So from a side effect profile standpoint, it would also be pretty terrible, I think. But very good thought. I'm glad you're thinking through like, okay, well, how could we fix this problem? Okay, if the supply issue is the problem, then let's replace the supply. But unfortunately here, not really a feasible option. So Just to give you some comparisons here between the different ones, all these are going to be reversible. We have tacrine, donepezil, rivastigmine, and galantamine, which I'll get into more detail here in a moment. You're going to see that initially when we had tacrine, wasn't a great drug. You see a lot of hepatotoxicity, relatively short half-life, so they had to dose it a whole very frequently. And then it wasn't very selective for the cholinesterase isoenzyme that we were shooting for. So because of that, it had really bad side effect profiles. It just was a bad drug, right? So since then, we've gotten much better because now we have things like donepezil and rivastigmine and whatnot. And so we're going to get into more details on these, but they help to mitigate a lot of these other side effects. And you don't have to do as much monitoring in terms of like hepatotoxicity, as we'll see in just a moment. So the first one here, donepezil, again, pretty specific for acetylcholinesterase, and it has a really long half-life, like 70 hours, which is good because now they don't have to take it one time daily, and so it does help out with the compliance with the medication because they don't have to remember to take it multiple times a day, right? So that's good. And again, you can see some metabolism interactions here. So if you had other drugs that are inhibiting something like CYP2D6 or 3A4, you can find levels of this drug would be increased, and that could cause more toxicity potentially there. So, be careful with things like ketoconazole or other azole antifungals. Those tend to have a lot of CYP interactions, as you'll see. But again, pretty good drug, long half-life, so compliance is going to be a little bit easier there. Here's one, rivastigmine or Exelon. This one has a short half-life, so you're thinking, well, that wouldn't be good because you're having to take it many times throughout the day. However, it's when it binds to the cholinesterase, it kind of covalently binds and sticks there for quite a while. So its apparent half-life is much longer than what the actual drug's half-life is there, which is good. It's still dosed twice a day, so maybe not as beneficial as something like donepezil, as an example. But this one is good because it really avoids any sort of drug interactions. So if I had someone who was like on a strong CYP3A4 inhibitor, they had to be on that drug, maybe donepezil wouldn't be so good, but rivastigmine could be a good option, right? So that's one benefit of something like rivastigmine over donepezil as an example. And then we have galantamine, again, pretty specific for acetylcholinesterase. This one's still dosed twice daily, so again, not as good as something like donepezil. And this does run into some of the same CYP interactions as donepezil there too. So one thing just to note. And again, the side effect profile is going to be those cholinergic side effects, but they're going to be fairly mild because most of these drugs have a tendency to mainly affect the CNS and will miss some of those peripheral effects. But, you can expect, chance or diarrhea is going to be a little bit better with this than something, like a routine over-the-counter med. If they had urinary incontinence beforehand, this can be worsened, right? So things like that you'd expect to see. So another way we could do that, so instead of just focusing on acetylcholine, well, let's focus on the degradation of the neurons themselves. Perhaps that could help. And so there's this theory that glutamate, being the major excitatory neurotransmitter, is causing excitotoxicity, right? It's causing too much excitability of these neurons that eventually leads to oxidative stress and eventual death of the cell, undergoes apoptosis. And so the thought would be that if you can have less glutamate activity, then that would kind of relieve some of that stress off of those neurons, and hopefully they would live for longer, and maybe even slow down progression of disease. So I think I have a slide about it. Yeah. So the one drug we have here is called memantine or Namenda. This is basically a glutamate receptor antagonist, and particularly the NMDA receptor there. And this is for moderate to severe cases of Alzheimer's, maybe when your acetylcholinesterase inhibitors have started to work less. You maybe add this on to those patients there. It does help improve cognitive function for them, and it's generally pretty well tolerated. So it's a good drug to add on a little bit later on in the process there. But again, what you can see here with this NMDA receptor, by having too much glutamate activity, you're causing too much calcium to come in. That leads to oxidative stress and eventually leads to apoptosis being triggered due to that stress. So by blocking this, you get less oxidative stress, hopefully, and hopefully prevent those neurons from dying off as quickly. Again, it's not been shown necessarily to be definitive in terms of delaying progression of disease, but it does help out with cognitive function, so good for symptomatic management for sure. Anyway, so it has a nice long half-life here. So again, single daily administration, which is very beneficial, and really no drug interactions because it doesn't undergo a lot of hepatic metabolism. Again, is it neuroprotective? I don't know, but probably is not a bad thing to try, especially as they get more progressive in terms of their disease. Right? So Not a lot of options there, unfortunately, for Alzheimer's disease. But let me know if you have any questions on those. Okay, the last section here I'm going to talk about, and this is more of a meaty section, is going to be about migraines and headache. So there's several varieties here you run into. I'm going to focus mostly on migraines because that's where we have kind of the most new medications that we're going to be running into here. So let's talk about migraines first. So what is a migraine? Well, basically what you're seeing here is that it's kind of a multifactorial process here, but essentially what you can see is that there is some kind of trigger that goes off initially that causes vasodilation of some of the nerve or some of the vessels up in the brain, right? This increase in dilation causes pressure to increase because you're letting more blood flow come in, right? That's going to cause pressure to build up, especially on things like the trigeminal nerve. This increase in pressure on that nerve causes pain and can trigger inflammation. It tends to kind of perpetuate itself for a while until the migraine eventually resolves. Again, you're going to find that this can present differently in people. Some people will have auras beforehand to where they know that they're going to have a migraine coming up pretty soon. They'll have some sort of sensory sort of changes where they know it's coming up. And then some people don't. They just get them sort of seemingly randomly. So the primary thing that our medications are going to focus on is to either deal with the inflammation. So things like NSAIDs can be useful here, or we can try to constrict those vessels that are dilated, constrict them down in order to prevent them from causing that increase in pressure on those nerves. Okay, so that's the main thing we're going to try to do there. So our goals for these patients are basically to try to decrease for the acute migraine, obviously you want it to stop, right? So we'll talk about what we call abortive therapy for these patients here, medications used to treat an acute migraine. And then in the long term, we're going to look at drugs we want to use in order to prevent them from having attacks in the first place, right? So if they have recurrent migraines, we'll talk about prophylactic therapy we can put them on. And again, it's important to know the distinction between abortive therapy versus preventative therapy, right? One's to treat an acute migraine, one's to prevent the migraine from happening, okay? Some of this is going to be non-pharmacologic, including things like stress management, avoiding certain foods, things like that, but we'll see there are some medications that play a role in terms of prevention as well. So we'll see that, some non-pharmacologic options are here. We'll talk about OTC therapy and how this can be useful to a limited degree, but its utility is going to run out pretty quick. And then we'll get into our prescription therapy, which is most of our new drugs here. So in terms of non-pharmacologic therapy, we can do things like behavioral management. So things like stress management. I'm sure most of you guys have no problems with stress at all, especially this morning at around 7:55. No stress whatsoever. But having a headache diary, I think, is really important too for these patients. If they can document when they have a headache, what was going on around that time. Was it, certain smells, sounds, foods, things like that. They can try to find out what their triggers are so they can avoid those things in the future. That's going to be probably the best sort of prevention you can do. And certainly things like regular exercise, getting, normal sleep patterns, things like that can all be beneficial. All things are easy to do in PA school, right? Absolutely. There are several food triggers along with this as well. So things like alcohol, especially, someone has dehydration associated with a hangover after a heavy night of drinking can lead to a migraine. Caffeine itself in too big a dose can lead to a migraine, but actually withdrawal as well can lead to withdrawal headaches. Foods high in things like MSG, for instance, or tyramine containing foods like those bougie foods we talked about before. All of those can be common triggers, and not for everyone, but you want to find out what in particular is affecting those patients there. But things like flickering lights, strong smells, really any environmental thing could be a potential trigger, and if you can avoid those for your patients, and or help them identify what to avoid, and that's going to be good from a prevention standpoint. So, as I mentioned, our pharmacologic treatment can either be preventative or for acute management. And then we will decide what we're going to use based off their signs and symptoms and sort of how often and how long they're having these headaches for, right? You will find, especially for patients with chronic migraine, some of you may even suffer from this, that you will have a cocktail that that works for you. You'll have patients that come in with migraine that say, yeah, every time I just get this, and this, just give that to me and I'll be fine. and that's what works for them, right? So it's good to listen to your patients, because if you try to give them something that they know doesn't work for them, they're not going to have a whole lot of confidence in your ability to manage them, right? Now, there's some things that may come in and say, "Oh yeah, only Dilaudid works for my migraines." Well, you're probably not going to get Dilaudid for a migraine, because there's no real role for opioids, as we'll see here in a little bit. But a lot of times they'll come in and they'll say, "Oh yeah, give me some Toradol, Compazine, and Benadryl, and I'm set." Right? We'll get into the drug therapy here, but again, listen to your patient. They know their bodies pretty well, as it turns out. So we'll see that you want to administer meds at the onset of the headache, especially if they have an aura preceding the migraine. That can be very beneficial. However, there are no meds to affect the aura itself. It's just one of those things that has to happen. And then generally speaking, we don't want them to use these more than 2 times per week. If they are needing it more often than that, that can actually lead to what we call medication use overuse headaches, to where using more and more medication just makes their headaches worse, as it turns out. So that's where we're going to get into our preventative therapy in just a little bit, as we'll see. So for acute treatment of headaches and migraines, you can utilize simple analgesics here, right? So things like NSAIDs tend to be pretty effective here. So your aspirin, ibuprofen, naproxen, those are all fine. Remember, a lot of people talk about using Excedrin for headaches, and always consider what's in Excedrin. And it can vary depending on the product that you're looking at, but frequently it'll have usually some caffeine in it. Now, keep in mind, if your patient's already drinking 4 venti Starbucks a day, may sound like an exaggeration. I'm sure there's someone out there like that. Then that can worsen if you give them additional caffeine. So consider what their intake is like already. Typically, acetaminophen can be a useful adjunct, but is not going to be effective by itself. Okay, so it's just not going to be able to usually take care of it by itself, but as an add-on, it can be pretty good. And then for most patients who come, if they're sick enough where they need to come into like an urgent care or the ER setting, most of the time they're going to get some Toradol, right? So ketorolac, Toradol, very good parenteral NSAID, very handy as long as they don't have any side effect or any contraindications, like later stage pregnancy, like bleeding disorders, active GI ulcers, things like that, because usually they're just getting like a single dose here. But consider too, ask them what they took just recently. Like, if they have a headache, they probably already took something for it at home, right? So if they just took, 800 milligrams of ibuprofen an hour before they come and saw you, maybe don't give them the Toradol right away, right? Maybe wait a couple hours. If they took 200 milligrams 6 hours ago, then yeah, hit them with the Toradol. It's going to be fine, right? Which these are things you'll pick up in your rotations, right? Generally avoid opioids. There's really no role to play for opioids here. So if they come in saying, and actually we just had a case we were running over yesterday with our students, and we had some people who are facilitators that work in ERs currently, and they were talking about all the, they have patients that will come in and say, oh yeah, only morphine works for my migraines, and they just flat out say like, well, that's not going to happen. You're not going to get that. We're not going to do that for a migraine just because there's really no role for it, And so, of course, you'll run into the factor where the patients will say, okay, well, I want to see the doctor. I want to see a doctor. I want to see a PA. I want to see a doctor, right? They run into that stuff all the time. And they say, okay, well, guess what? The doc's going to tell you the same exact thing. And sure enough, the doc will come in and say, nope, you can be discharged. You're good to go home. So you'll run into those challenges frequently with patients who may be exhibiting pain-seeking behaviors. But for migraines, true migraines, opioids are not needed here. Another feature, though, that you will want to address is the nausea, vomiting, and so you want to consider to, does the patient have a ride home? Do they need to drive themselves home? This will kind of dictate, what drugs you select here. Typically, these patients are, so debilitated by their migraines that it's really a challenge. They probably wouldn't be able to drive anyway because they're so phono or photophobic. They're just so miserable that if you give them something sedating, that's probably fine. They probably want to take a nap anyway, right? But if they need to be awakened with it, then, use something non-sedating. So kind of keep those things in mind here. Typically, we'll go with our phenothiazine antiemetic. So a lot of people clinically get a lot of use out of using a combination of prochlorperazine or compazine, and they'll actually use that with Benadryl, and they get pretty good activity on nausea, vomiting. That's just a common thing you'll see with migraines. But there's nothing to say something like Phenergan would work well, metoclopramide works well. And again, ask the patient what they've used and what works well for them, because they'll probably know and they'll probably tell you, right? Unless it's their first migraine. as I mentioned with Zofran, that's going to be good for non-sedating aspects of it, and so that could be better if they need to, like, say, drive themselves home, for instance. And again, you're going to find a lot of our abortive medications, which we'll get into in just a moment, tend to cause pretty severe nausea and vomiting. So by giving this early, you can sort of help to mitigate that once you get the other drugs. So for more moderate to severe migraines, this is where we're going to get into our ergots first, and then we'll talk about our triptan drugs in just a little bit. Ergots, as I mentioned, are vasoconstrictors. That's why I talked about that St. Anthony's fire and how it caused that terminal vasoconstriction in the fingers and the toes. Keep that in mind because that's going to belie a lot of the side effects we're going to run into with our ergots here in just a few moments. Interestingly enough, ergot fungus is also a precursor to LSD, or lysergic acid dimethylamide, I believe is, I haven't looked it up in a while, but LSD, the hallucinogenic drug, which is kind of interesting as well. That's why you can see some hallucinations with that stuff. But anyway, the two primary ones we have here include ergotamine and then dihydroergotamine, or DHE. I've probably seen more DHE used more than anything else. Again, keep in mind the dosage forms here. Like, why would you want to use a suppository? Well, if they have a migraine and they're actively vomiting, maybe oral product is not going to be sufficient, right? Or DHE like has a parenteral product available to use IV if they're, in that setting. These are going to work by activating the 5-HT1D and 1B receptors. If you recall, 5-HT is a shorthand for serotonin. So by activating the 1D and 1B receptors, you cause vasoconstriction to decrease increase constriction of those vessels, decreases the pressure on the trigeminal nerve, and relieves a lot of that inflammation and pain the patients are going to experience. Okay. You'll also find that there's some presynaptic activity where it can help with inflammation and pain, but the primary thing is the vasoconstriction it does on the 1D and 1B receptors. So other benefits from the ergots are they have a generally long half-life, and so this helps to decrease the recurrence when they go home from, say, the urgent care or the ER that they're going to experience later on. So that'll be a challenge with some of the early triptans we'll see here in a little bit. But problems we're going to run into and some of the side effects include pretty significant nausea, vomiting, which hopefully you've pre-treated already. You can see increases in blood pressure, which makes sense because it's a vasoconstrictor. And you can even see things like ergotism, which is sort of the signs and symptoms associated with use of ergots. And it kind of goes back to that St. Anthony's fire story I talked about. We get these cold, numb, painful extremities, and paresthesia is associated with the fact that they're having impaired circulation, especially the toes and the fingers. And that has led to cases of MI. It's led to cases of bowel and brain ischemia. So these are not common things, but these are things you want to consider, especially if they have like a prescription for an ergot at home that they used right before coming to see you. You probably don't want to give them any more ergots, because if you start to dose stack those, that's where you run into problems, right? In terms of contraindications, a lot of them are going to go right back to the side effects there. So if they have history of like vascular coronary disease, history of hypertension. Now, this is a relative contraindication. It's not to say that anyone with hypertension can't get it. It's more so like the uncontrolled hypertensions. So if someone's on 10 milligrams of lisinopril a day and their blood pressure is 113/75, yeah, of course they can get an ergot. That's fine. If they are on 3 blood pressure meds and they come in and it's 180/100, that's good. I'm not going to give that person DHE, right? Another big thing here too is that you would not want to constrict the vessels in a developing fetus. So this is going to be what we call a category X drug for pregnant patients, meaning there's no case to ever give it to a pregnant patient, because we know there's just pretty significant harm can be induced in a fetus. So again, we have other drugs we could treat the mom with, so no reason to give that. So don't do it for pregnancy. Always check a pregnancy test beforehand. And if you think about which patients are more likely to develop migraines, it's typically females. So again, if they're of childbearing potential, go ahead and check it out, right? And then look for renal and hepatic dysfunction, because again, you can affect the vessels there as well. You also do not want to use these within 24 hours of the triptans. Triptans are the next class of drugs we'll talk about, but they can cause synergistic vasoconstriction, which is not something we want to do. So getting into the triptans, it's kind of a colloquial term we use for these. You can tell if a drug is a triptan because it'll end with triptan. We basically had sumatriptan as our first generation drug here, and then we had several sort of follow-up drugs that came after that. So Sumatriptan is kind of considered the first generation, then everything else is sort of a second generation drug. You have zolmitriptan, rizatriptan, naratriptan, almatriptan, brovatriptan, and then elatriptan. The reason why we have so many is you're going to find there's some differences in terms of like half-life. You'll find there's differences in terms of onset of action. You'll find differences with some drug interactions we run into. So those will be some of the differentiating factors that will guide you to picking one versus another. But I think for a long time the gold standard's been sumatriptan just because it was the first one that came out, and it's just been used for the longest period of time. So most people feel comfortable with it. And it's relatively cheap compared to some of the newer ones there. And again, note there's a lot of different dosage forms available. You can give it sub-Q, you can give it intranasally. A lot of different options that are going to be used there. I guess I just put IN instead of NS. I don't know what I was thinking there. Intranasal. Sub-Q, oral. So a lot of different options that are available from that standpoint. So their mechanism is exactly the same as the ergots, right? So they're activating 1D and 1B receptors to cause a vasoconstriction of the cerebral vessels to decrease pain, pressure, inflammation, all of that good stuff there. One of the downsides of sumatriptan in particular, when it came out, is that, yeah, it has a favorable side effect profiles compared to the ergots. Again, the ergots have been around for forever. But one of the benefits of sumatriptan is it had a better side effect profile. But we did see that its duration of action was shorter than the ergots. And so while a lot of patients got initial effectiveness out of it, they did have some degree of recurrence the same day, right? And so you don't want to send your patient home after having a migraine, and then they have a migraine later on that day. They'll think they weren't really treated that well, right? You'll see that is decreased with some of the longer acting agents, though. So particularly Frova and Emerge, you'll see that's a little bit better. So what are some of the side effects you're going to see here? And again, that's a more favorable side effect profile than the ergots, but still you're going to have side effects here, right? Most patients will develop this. But you can see things like chest tightness, some pressure and pain. Again, this is going to be another case where you don't want to give this to patients with a history of like angina or myocardial infarction, just because you're constricting those vessels and you want to make sure the heart has plenty of blood flow, right? But some other things like paresthesia, somnolence, asthenia, things like that, you can develop not every patient will develop these, but these things can happen. Just note the contraindications here. Pregnancy is not an absolute contraindication, but I'd probably avoid it and use other options if you have the ability to. It'd be on a very case-by-case basis, and something I want to talk to the OB-GYN person about as well before using. But history of like coronary artery disease, cerebrovascular disease, PVD, any of those I would want to avoid using those patients. And if they're on any monoamine oxidase inhibitors, so just like we saw with selegiline or rasagiline, or if they have had ergots within the past 24 hours, I would definitely avoid using a triptan. How we choose one, typically people just go sumatriptan, at least to start with, just to see how it's going to work for your patient, because again, it's relatively available, it's cheap, most people have used it. Most clinicians have experience with it, so it's easy to recommend first off. And your patient will likely tell you whether it works for them or not. They'll say, "Oh yeah, sumatriptan doesn't touch my migraines." That's okay. Listen to your patient and let them tell you what works for them. But again, they're going to find that the shorter half-life drugs typically have a faster onset. So for instance, here, if I do like a sub-Q injection, I get about an hour before the efficacy kicks in, maybe about 2 hours for the intranasal, the PO forms. You're going to find it's longer for the drugs that have a longer half-life. So there's a trade-off here between faster onset of action versus recurrence. So if I have a fast onset initially, I'm probably going to have more recurrence later on, versus if I have longer half-life, I'll have less recurrence, but a longer time for it to really kick in. So as I mentioned, second generation drugs are designed to either increase the bioavailability of the drug, decrease headaches, or the recurrence of headaches, and some of the side effects here. And so they're able to either get into the CNS more easily, they have better half-lives or bioavailability, or they have a greater receptor potency. So that's the goal of some of these second generation agents here. So they're all a little bit different in terms of their activity. So I just want to kind of focus on some of the highlights here between some of the different ones. So for instance, like naratriptan has higher bioavailability, has longer half-life, so you'd be expected to have less issues in terms of recurrence down the line, which is good. But look at the onset of action, like 4 hours as compared to 1 hour for something like sumatriptan. Also, because it's a slower onset, you'll find a better side effect profile, not as much chest tightness and pain associated with that as you would with sumatriptan. So that could be one benefit. However, you don't want to give it to patients with renal or hepatic disease because they will not be able to clear the drug as well. Rizatriptan is pretty interesting because of a particular drug interaction it has, where you will see that when given with propranolol, which is something we'll see that's used for prevention of migraines, you actually get a big increase in the AUC of the drug, which is basically a measure of total drug exposure, meaning you're going to get way higher levels of the rizatriptan, which can lead to more side effects. So if you were to combine this with propranolol, you definitely want to decrease the initial dose and see how the patient tolerates it before trying to titrate up on it, right? This one has the fastest onset of action of all the triptans, so it's kind of beneficial from that standpoint. But notice here how the dose drops if you're taking it along with something like propranolol. It's like cut it in half, basically. Almatriptan has the best bioavailability, but you can see some interactions here in terms of its with if they had a CYP3A4 inhibitor on board, or if they had like a monoamine oxidase inhibitor, this could lead to higher levels and more side effects potentially. Elatriptan is also metabolized by CYP3A4, so you would want to be aware of that. And then frovatriptan actually has the longest half-life here, one of the longest, 25 hours. And so you would see that while clinically acts like neurotriptan, has a pretty low recurrence risk, which is nice from that standpoint. Someone is saying, would oxymetazoline work to relieve migraines, or is its effect pretty much localized to the nose or sinuses? Yeah, so if you took a vasoconstrictor like oxymetazoline, think about how it works. Mainly by activating the alpha-1 receptors, right, to cause local vasoconstriction. That's not going to be as specific as it is for the CNS. So could you get some utility out of it? Maybe, but also you're going to run into issues of like increased blood pressure, more so than you would see with something that's more specific for those serotonin receptors. So, yeah, that would not be recommended. The nasal spray aspect of it means it works pretty locally, so you wouldn't expect a lot of systemic effects. But say, for instance, someone took pseudoephedrine, right? That would be a systemically active drug. Could that work for their migraines? Maybe, but it's not going to be as effective or specific as something like a 5-HT1B or 1D agonist like DHE or sumatriptan. But good thought. I'm glad you're thinking kind of like, okay, well, what are some other ways we could do this? I like that thought process there. It's good. So anyway, so for acute management, as we said, manage the nausea, vomiting. You can use NSAIDs if they don't have any contraindications, like Toradol is probably most common. And then utilizing one of these abortive therapies for more severe migraines these patients might have. They're having a lot of nausea, vomiting. Probably skip the oral routes if at all possible. And then remember, parenteral routes like sub-Q or IV are going to have faster onset than something like PO or intranasal formulations. Make sure you don't use triptans within 24 hours of ergots. You're going to see excessive, prolonged vasospasms. You don't want to do that. And then again, try to avoid using more than 2 days per week of abortive therapy. At that point, they probably need to have some sort of preventative therapy on board in order to help manage that. So you can see here basically the algorithm, how you kind of go through and manage these patients here. So once you have the diagnosis of migraine, and again, this will probably be handled by, you may be the first person to see them and diagnose them with the migraine, but they'll probably be followed by neurology to get more definitive care here. And so you're going to see, okay, well, how disabling is this migraine? How, are they have to call out of work every time they have a migraine, or they can't go to school? At that point, you want to go ahead and consider prophylactic therapy, right? For more mild to moderate symptoms, again, utilizing simple analgesics, acetaminophen, NSAIDs, that's all fine there. You can utilize combinations. So, for instance, Excedrin typically has a combo of acetaminophen, aspirin, and caffeine. But recall, if they already have a lot of caffeine in the system anyway, then perhaps that's not something you want to be utilizing there. When it comes down to severe symptoms, or if these are not working, then you get into your triptans or ergots. Either one of these are fine. Just remember your contraindications there. Remember that the ergots typically are going to have more of the vasoconstrictive symptoms, but they also last longer, so less recurrence than the triptans. Some people will just know what works for them. They say, okay, triptans don't really work. Give me DHE, right? And patients will call it by name. They know what they like, and that'll help out too in kind of guiding your therapy choices there for them. Someone had a question here. So for Provertriptan, how long is the onset if it has such a long half-life? It's probably going to be similar to the Neurotriptan. So if you want to look back at that slide. So Neurotriptan is probably closer to that 4 hours, I would say, if anything, in terms of the onset of action. So yeah, you can kind of think about those two pretty similar in terms of that. Oops. Let's see here. Someone said, could using both triptans and ergots together by accident cause a CVA? Yeah, it could. So I would be very cautious there, especially with patients with a history of any kind of cerebrovascular disease for sure. So definitely ask the question, like, what have you already taken for this migraine? When's the last time you took it? And all that can really help you to guide your therapy, especially. So make sure to ask the questions, get your history. All right. So anyway, so medication overuse headaches is something where you can find patients either overusing opioids, ergots, triptans, or other analgesics, say greater than 15 days per month, right? Or if they're using more of those abortive therapies, more than 10 days per month, you tend to find these patients, their migraines are getting worse, and it's actually due to just being overtreated with so many medications. And so basically the best thing to do is try to wean them off of it as best you can, especially by initiating some prophylactic therapy, which I'll get into in just a little bit here. Typically, it does take some time to kind of wean them off of it, and it can be challenging because that's the only thing that works for them. So you got to go and get some more. But by weaning them off slowly over 2 months, hopefully, you can get their overall use down, which is going to be good. For some patients who are especially taking quite a lot of medication, you don't want to abruptly discontinue it, or if they have something like pregnancy or something where causing abrupt changes in their regimen, especially this heavy of a dose, could cause issues. So in those cases, you can try and titrate them off. If they're using more moderate amounts, then they can cut them off cold turkey. That's generally fine. But either way, you want to go ahead and begin prophylaxis medications in order to prevent them from having recurrent migraines and headaches. So what do we do for preventative therapy? Well, these are going to be for people with like recurrent frequent migraine, or especially despite acute treatment, or if they have maybe contraindications getting other meds, patient preference, a lot of reasons to decide to do preventative therapy here. And so first line, you can see that classically we've used beta blockers, especially propranolol. I think has probably had the most utility just because it's fat soluble and it's able to get into the brain pretty easily. But there's nothing special about it. Any beta blockers are fine here. The thing here, and again, you think a beta blocker, okay, can that cause some vasodilation? Wouldn't that cause a migraine? Well, yeah, it could, and especially if you go kind of full dose right away, you can actually cause a migraine to occur in these patients. So what do is start low dose and gently titrate up, and over time, you're going to see that actually will decrease the number of episodes that they're having. Okay. So by blocking vasodilation and affecting some serotonin release from platelets, is able to help prevent those migraines from occurring, right? Keep in mind, if they have like asthma, use a beta-1 selective drug, right? All those things still apply here. You also find that some anticonvulsants can be used as well. So things like valproic acid, which we talked about earlier, and topiramate are particularly popular. These are good for patients that may have like low blood pressure, low heart rate, those that may not be good candidates from a cardiovascular standpoint. This could be a good option, right? But if they have like high blood pressure, then if propranolol can serve two functions, then that's a good thing. Two birds with one stone is always a good thing to attempt. If they have a seizure disorder, then yeah, these are probably good options to try for them in treating their migraines there. I'm seeing people like topiramate because it has a little bit better side effect profile in terms of like causing CNS depression versus something like divalproic or valproic acid. So some people like that. It can even cause some weight loss because it can cause decreased appetite. So again, that could be a side benefit there. Again, these aren't working necessarily on the vessels so much. They're more so just inhibiting the kind of overactivity of things like the trigeminal nerve. They don't get that kind of spreading wave of seeing depression there that causes those migraines to happen. Someone said, how do you manage migraine prophylaxis with those who are already hypertensive? Are there any hypertension drugs that are contraindicated with these meds? Migraine prophylaxis with those who are already hyper. Yeah, so for that, in that case there, and actually let me get back to that. Let me get to the drugs. Finish talking about the drugs. There's another class we'll talk about here. I think I talk about it. Yeah. So other things you can use include some of the antidepressants. I'm going to get into these in the behavioral health section coming up next. But this can include your tricyclic antidepressants, your SSRIs, This is probably not frequently used. It can actually worsen migraines. So this includes things like fluoxetine and paroxetine. Again, I'll get into those next section. But they're basically affecting the reuptake of norepinephrine and serotonin. So that way they can actually kind of help regulate the kind of the dynamism, I guess, of the cerebral vessels to try to keep them from dilating widely. It kind of keeps them more steady. So that way you can try to prevent a migraine. But to go back to the question, you can also try things like calcium channel blockers. So something like verapamil has had some good activity here. Things like nifedipine has been useful as well. And so the question is, if you already have someone who's hypertensive, try to use something like a calcium channel blocker or a beta blocker. And again, start low and titrate up because again, they can all induce migraines themselves. The cardiovascular drugs. So titrate them up and see how that's managed there, right? So that would be a good option to try either a beta blocker or a calcium channel blocker for those who are already hypertensive to begin with. I wouldn't say any of these are necessarily. I wouldn't say any of these are necessarily contraindicated with any of these medications that I know of, at least. So. And even something like botulinum toxin, right? So most of you probably think about Botox in terms of its use as an aesthetic drug, right? To help with maybe some. I had to learn a term from my wife the other day. To talk about the 11s, which I guess is where you like squint your eyes, you get like two lines right here. I guess that's where Botox can help. You can tell I don't have any because I can still form mine pretty well. But if there are certain muscles that are pulling on the head that can cause some of those migraines, especially like in the back of the neck, some of those muscles can be particularly tight and can cause migraines. You can actually inject botulinum toxin to paralyze those muscles to a degree, and that will allow them to relax. And that can help to treat those migraines. So again, just because you see someone getting Botox doesn't mean it's necessary for aesthetic purposes. It could be for usually to try to paralyze a muscle that is too spastic, I guess. So either cerebral palsy. I've seen a lot of cases of that. Botulinum toxin for headaches. All kinds of reasons. Basically, for preventative therapy, make sure to start low and go slow. And you'll basically consider it effective if you can see a decrease in either the frequency or duration of the attacks by about 50% or more. That's considered to be a success there. And then try it for 2 or 3 months, see how it does. If you want, you can consider tapering. And if they come back, then you can put them back on the preventative. Just depends. Just be aware of like interfering medications. Again, if you can try to hit 2 birds with 1 stone with a drug, that's always going to be beneficial. And that's why you mentioned like consider those coexisting conditions when trying to choose which med might be best. So if I had a question on an exam and I said, okay, you want to start preventative therapy for migraines in this patient, they have a history of depression, well, then maybe something like a tricyclic antidepressant is going to be a good option, right? If I say they have a history of AFib, maybe propranolol is a good option, right? So those are things you want to consider there when thinking about what drug to select. So, and again, looking at this kind of goes to those different comorbidities and how you might choose one versus another, right? So, for instance, if they have a history of hypertension or angina, use a beta adrenergic antagonist. If they have depression or insomnia, TCA, seizure disorder, or bipolar disorder, anticonvulsants, right? So all this kind of makes sense based off the comorbidities they have. Because again, if you can use fewer drugs overall, that's always going to be a good thing. I know that's probably blasphemy for a pharmacist to say. It's probably not good job security for me, but I always like it when you can use fewer drugs. It's always better off for the patient in the long run. So anyway, any questions on that? Pull the next PowerPoint here. Yes, I probably shouldn't get into my aesthetic routine with you guys. It's probably not professional. Talk about my routine for that stuff. But when have I worried about being professional? Probably not, never. Anyway, so next let's start up with our the remaining time we have. Let's start out talking about some of our behavioral medicine topics because we are woefully behind, but that's okay. We'll catch up. I want to start out by talking about major depressive disorder, something I have likely induced in. Let's see, I've been doing this for 5, 6, 7 years now, so probably hundreds of students. Not my proudest moment, but kind of goes with the territory. Anyway, this is something you're going to run into all the time, especially thinking of COVID times. It'll be wild to think how much this will change the incidence of things like depression, anxiety. And remember, oftentimes these two conditions go hand in hand, right? Depression, anxiety, they oftentimes worsen one another, compound one another. It can be pretty nasty here. Someone's asking, can I explain the mechanism of triptans again? So the mechanisms of triptans and the ergots are identical. They're both going to be activating the 5-HT or serotonin 1B and 1D receptors. Those cause constriction of those vessels, which relieves pressure on the trigeminal nerve. They also help to decrease presynaptic release of peptides that cause pain sensitivity and inflammation. And so that's a side benefit of those drugs. But it's really the vasoconstrictive action is what we're looking for there. Oh, you don't have access to the PowerPoint? Oh my goodness. I apologize. Yeah, I guess we are switching sections here. Let me put that up real quick. Apologize, you guys. I didn't even think to look at the course. Oh my. This is embarrassing. But an issue I can resolve. Great rapidity. Okay, you should be able to see it now. Can anyone confirm that? Published it. It should be under section 2, I believe. Perfect. All right. Sorry about that. Yeah, I apologize. Anyway, so hopefully you guys can pull that up. It'll be a couple minutes before we get into the actual drugs itself. So this is kind of just the preamble. But anyway, so now that you have the PowerPoint, so it's handy. So as I mentioned, you know, depression, anxiety are fairly common there, and again, they typically affect patients simultaneously in a lot of cases. It could be one or the other, but we'll talk about ways to manage that. As we'll see, and we'll see that like with initial pharmacotherapy, like, you know, we had therapy since like the 1950s. The older drugs that we had, like, it's basically, it's not that they aren't effective, it's just their side effect profiles are just terrible. And so we're going to see with the newer drugs that we have, their side effect profile gets much better because their mechanisms get more specific towards treating what we think is fixing the depression. And I'll get into that in just a moment. But basically, you're seeing as well is that more and more of you providers who are going, especially into primary care, are being expected to manage these psychiatric illnesses, right? It's not just a purview of behavioral health people now, it's really anyone, right? So because of that, that's why it's important to get training and experience in this because, you know, routine depression, anxiety, you may be the first person that is going to be managing that patient there. So, and again, it's really difficult to determine how effective the drugs are. This is because especially with depression and anxiety, there's a huge placebo effect that happens here. So imagine if you were a depressed patient and you were getting enrolled into a study where you didn't know if you're getting active drug or placebo. Just thinking that you're getting something that could help your depression may make you feel like you're helping yourself and your depression is actually getting better. There's a huge amount of mind over matter here when it comes to determining how effective our drugs are. So we know they work, but it's, you know, there's a huge placebo effect to consider here as well. Also, you know, a lot of studies had bad defined outcomes, and, you know, just a lot of reasons why the therapy is not, the literature is not clear on what the absolute best drug is to use for depression. There's going to be a lot of trial and error, as we're going to see here in just a little bit. Keep in mind, there's a lot of secondary reasons for depression and anxiety, and so you want to make sure you're addressing those. So things like hypothyroidism, inflammatory conditions, all can either worsen a patient's depression or can maybe mimic the symptoms of depression and anxiety, as the case may be. A lot of drugs that can do this too, many of which we have talked about. Things like isotretinoin used for acne, things like corticosteroids and beta blockers, and all these things which may mimic the effects of depression or can worsen someone's pre-existing depression and anxiety. And so it's important to consider that when thinking about which medications a patient's on and if you need to switch them over to something else, right? And the big problem we run into is that if this is underdiagnosed or undertreated, many of these patients will go on to try to commit suicide, right? And of course, this is where I got most of the work as a toxicologist, is patients who have tried to harm themselves. And, it's a very sad time for them. It's usually the worst time of their life. And, oftentimes they'll try all kinds of different things, whether it's chemical or, weapons or whatever the case may be. And frequently you're seeing is that they just haven't really been taken care of well. They just haven't gotten the therapy that they need, in terms of either both pharmacologic and non-pharmacologic. And so as a toxicologist, my job is to get them through that period, and that way they can get back to in the capable hands of psych providers in order to try and get that under control. But yeah, I see a lot of really sad patients, and unfortunately, one of the challenges here is that many of these patients that try to commit self-harm, they'll do so with their medications. And depending on what we've have prescribed for them for their depression, anxiety, can be quite dangerous, as we'll see here in just a little bit. So it seems silly, like you're giving someone a prescription for something supposed to make them feel better, and then it ends up being the thing that kills them potentially, right? Or at least causes them to be hospitalized. So again, it's a challenge, right? In terms of anxiety, I think that there are many different, not just I think, but there are many different sort of subheadings under the blanket term of anxiety, which include things like panic disorders, PTSD, obsessive compulsive disorders, and so these are anything that are really trying to interfere with their normal function by sort of triggering this sort of stress response. And again, you can find that depression and anxiety go hand in hand with one another, and so it's important to address both of those. And so we'll see their therapy that we have for acute anxiety, but more often than not, we're going to see that by treating someone's depression in the long term, you're also going to be treating their anxiety in the long term as well. Okay, so I'll talk more about that later. So why do people become depressed? We don't really know, right? We thought for a while it had to do with things like having deficiencies of catecholamines like serotonin, norepinephrine, dopamine. We thought that for a long time because there's this really old drug called reserpine that worked as an antihypertensive by basically depleting these monoamines. It basically got rid of your levels of norepinephrine and serotonin, and they found that a lot of those patients became depressed. And so they kind of put two and two together, and said, okay, well, this makes sense. Okay, if we give them more of their neurotransmitters, then they should fix their depression. However, what you're going to find is that the antidepressant effects are not immediate. It takes weeks before they will really kick in. So there's likely something more complicated going on downstream of just increasing serotonin levels, right? So maybe it has something to do with gene transcription or receptor sensitivity or occupancy. So really we don't know why these drugs work necessarily, but we know they do work, right? And it's important to consider that it does take a while for these to kick in because, imagine telling a depressed patient, here, take these meds. They're not going to work for a couple of weeks, but you'll get the side effects right away. They're probably not going to want to stick with it. And so compliance is going to be a huge challenge for all these patients, whether we're talking about depression, bipolar disorder, schizophrenia, all this is going to be a challenge. So obviously we want to reduce our symptoms of acute depression, hopefully get them back to normal functioning, and then if we can, prevent future episodes. So you'll typically find that patients will kind of go through various phases of treatment, whether it's kind of getting initial remission of symptoms by picking and selecting out, initial medications for them and try to kind of playing around with what dose you're using and which meds you're using to get their symptoms initially under control. And then they'll move into more of a continuation phase and maintenance phase where hopefully they'll be kind of just kind of trucking along. Things are good. However, they can have exacerbations, just like with any other kind of chronic disease state. And many people do require lifetime therapy, especially if they've had 2 or 3 more prior episodes, right? Some people, it just may be an episodic thing, especially if, like, you imagine, the COVID quarantine, once things, if ever, go back to normal, perhaps that patient may never have depression again. Yeah, it was just the fact they were cooped up for, a year. So it really just depends on sort of the situation the patient's in. It depends on a lot of factors. But again, adherence, super critical for these patients. For non-pharmacologic therapy, this is absolutely critical for patients to partake in because you will find that while the drugs can be effective on their own, they work even better when used with some of these non-pharm therapies, especially things like cognitive behavioral therapies. Things like that can be really useful. And it may even seem shocking to you, but some people even still benefit from electroconvulsive therapy. It's kind of a old barbaric sort of thought to shock someone, but for more really resistant cases, we may even still use that, right? And there's newer therapies that may not be quite as proven. Just as an example, there's something called repetitive transcranial magnetic stimulation, where you're actually using magnets and sort of beaming these magnetic forces through the brain, and some people swear by it, right? So there may be newer therapies as time goes on. Some may be snake oil, some may actually show to be really good. So moving forward, let's talk a little bit about our pharmacologic therapy since I have some more time here. As I mentioned, it's difficult to determine who's going to respond well to a particular drug. And if you look at the studies, like there's like a 30 or 40% placebo response rate, right? That's wild if you think about it, because if you give someone a placebo antihypertensive, you wouldn't expect their blood pressure to really go down much at all. But here, again, mind over matter is an important consideration. And so just giving someone, even if it was not a real drug, could still benefit them if they thought it was going to benefit them, right? So how we choose our drugs is going to be more based off of things like concurrent medical illnesses, so like what other disease states do they have to contend with, what drugs they might be on. So drug-drug interactions is important. Also ask, like, what have they tried in the past? What has worked for them? What has not worked for them? Because obviously you don't want to give them something that does not work for them, because they will not think you're a very good provider if that's the case. And then the adverse reaction profile is going to be huge, because which ones we select will dictate what adverse effects they have, which may be a reason for premature discontinuation. One thing we'll see with most of the antidepressants is a lot of them cause sexual dysfunction, either decreased libido, or they may be developing things like anorgasmia and just all kinds of issues that maybe leading to more stress in their life. And they say, okay, well, I don't want to take this stuff anymore, and they'll just DC it, And then they'll come back and you'll ask them, they'll say, oh, how's the medication going? Are you taking it every day? And they'll say, yeah, I'm taking it. It's fine. And, they just may tell you what you want to hear, because they don't want to get the scolding from their medical provider, So a lot of things to consider here with these patients. And again, they may not always be very forthright with you unless you're able to kind of open up that line of communication with them. So again, it's really important when you're talking to these patients to be curious about these things and not judgmental, right? And say, okay, well, are you having any challenges with the medication? What sort of issues are you running into with this? And keep it open ended to try to have them be more forthright with you, and that can go a long way with communication with your patients, right? A little bit of a side note, but typically we'll classify our different antidepressants either based off of chemical structure. So if you hear me say like a tricyclic antidepressant, you can be pretty well assured they all have a tricyclic structure, but they all act pretty similar to one another. Or we will base them based off of their mechanism of action. So when I say like an SSRI, the selective serotonin reuptake inhibitor, that's what the drug does. That's its mechanism. And it's not necessary that we classify these based on their link to the therapeutic effect, but it does help us to understand a lot of the adverse effects that are going to be seen that are directly related to their mechanism, right? So the side effects people get are related directly to what the drugs do. The clinical effects maybe not so much, not as clear. Typically, we're going to give an antidepressant drug 2 to 6 weeks to see full effects. If they have not really gotten any benefits by that period, then the drug's probably not going to work for them. Either they need a dose change or they need to switch drugs over, entirely. And you'll find that the adverse effects are going to be immediate, right? The first time Am I back? Sorry about that. I think I got disconnected there for a moment. But I'm back. I apologize about that. Yeah, my software just said, hey, you're disconnected. I was like, oh, that's not good. Anyway, I'm not sure where I got cut off at, but yeah, so anyway, it takes 2 to 6 weeks to get full effects from these drugs. Again, side effects are gonna hop in pretty much. All right, sorry, hopefully it'll correct. My connection looks good, but it should pick back up in a second. But again, the side effects should mitigate with time. It should go. Typically, you're going to find that if patients, okay, good. You're going to find that with the failure rates with these, it's either due to perhaps just an intrinsic resistance to therapy, could be a pharmacogenetic sort of thing. They either didn't have good enough drug dose or duration to try it, or there's non-compliance, right? So if people stop taking it due to adverse effects, or maybe there's a delay in getting them therapy. Something like that could be a reason why it does not work. But you can find between a fifth to a third of patients may fail with these initial therapies here. So, as I mentioned, placebo effect is really big. So this is why, and again, some people just have natural remission of their symptoms within a period of time anyway, right? So let's say the COVID lockdown ends, you're able to go back to normal life, then perhaps that will fix depression for some people. So some of these things may be more situational, but you may have some patients that will develop recurrence of symptoms, and that's why we keep them on drug therapy for longer in order to, kind of trying to prevent those recurrences from happening. With the what you're going to find though is that as we go through the different classes of drugs here, that the side effect profile is quite different, even though all of them can be equally effective, such that especially at therapeutic doses, side effect profiles can be very different. Also in overdose. So as an example, if you were to compare tricyclic antidepressants, which we talked about for like neuropathic pain, but originally was an antidepressant class used just for that. If I had two patients and one of them had overdosed on a TCA, and I had someone that overdosed on an SSRI, I am extremely more worried about the patient from the TCA dying than I am about the SSRI, right? So like a scale of like 1 to 10, I'm like an 11 or 12 for the TCA patient and like, a 3 or a 4 for the SSRI patient. So the benefit is a lot of the newer drugs are much safer. So that way, if you give it to a patient, and you'll see a black box warning for a lot of these is actually increased risk of suicide, which I'll get into a little bit later, is that if you give them a prescription, you don't want to be giving them something they can really harm themselves with. And so that's the benefit of the newer drugs, is they're overall much safer. And so as you go through the different classifications here, you're going to see that with the basically the older agents are going to have more side effects. This is where we're going to get into like our monoamine oxidase inhibitors. Initially, these are going to basically be preventing breakdown of serotonin and norepinephrine. We'll then get into our TCAs, which is where we have the reuptake inhibition of both serotonin and norepi. And then we'll get into our selective serotonin reuptake inhibitors. This is kind of like the newer set of drugs that like really have much better safety profile than the TCAs and the MAOIs. And then from there, from the SSRIs, then we developed the selective serotonin norepinephrine reuptake inhibitors, the SNRIs or SNRIs. You may hear it being referred to occasionally because that's just fun to say. And these are going to work on both norepi and serotonin. Okay, so you're going to see as the drugs progress, they're going to be getting more selective for their specific targets, and thus are going to get better side effect profiles because of that, because they're not going to be affecting a whole bunch of other receptor subtypes. That's kind of the benefit there. So just to give you an example how these drugs are going to be working, imagine you have, say here, a noradrenergic neuron, and here you have a serotonergic neuron. Basically, 5-HT is serotonin, so just make sure you're familiar with that. And you're going to have the postsynaptic neurons here as well. And in order to and so normally what you're going to find is these vesicles will release norepinephrine and serotonin into the synapse where they can interact with the postsynaptic receptors, right? From there, they will normally get, because the brain wants to, recycle things if at all possible. It's just more utilitarian in that way. Is it will then reuptake and recycle those. It's trying to be, kind of cost conscious here. So it's going to reuptake through these transporters, and then eventually some of that norepinephrine or serotonin gets broken down by monoamine oxidase, just like we saw with dopamine for Parkinson's. So a couple of ways we can interact with this system here. So one, we can use the monoamine oxidase inhibitors to block the breakdown, so there's just more of it to release. That's one way to do it. Or more commonly, we're going to find that by blocking the transporters here, you can prevent the reuptake, and thus more of it's going to be sitting out in the synapse here. And then something happens downstream. We're not really sure what, that causes depression to be fixed, basically. So that's what we're seeing there. You'll see that there's some differences in terms of selectivity. So for instance, SSRIs only work for the reuptake of serotonin, whereas like your TCAs and SNRIs work for both. Okay, so that'll be some of the distinctions to make there as we get into the individual drugs. So as I mentioned, in terms of mechanism, in general, they're enhancing the activity of norepinephrine and serotonin, even though we don't know the full mechanism. There's probably something happening down the line, and maybe by the time you guys are all graduated and working clinically and then become teachers, maybe you'll know eventually, but right now we don't really have a full story on the whole thing there. So I think I'm going to cut it off there for today. One thing I wanted to address, I was looking at my evals from the last course. I know someone was talking about how they wish they had more time in the course. and that, we're always ending early. To be honest, that's kind of by design. Normally, if we were in person, we would do two 50-minute blocks because one, we would do like 8 to 8:50, get a 10-minute break to kind of like recoup your mind, just kind of like reorganize yourself in order to get ready for another hour, and then usually have that 10-minute break to get to your next class. And so I tried to replicate that by just doing straight through 100 minutes, and so you get basically the same class time. But also I find that if I tried to go for the full 2 hours, I think that would just be too much for you guys in terms, and this is for anyone. Like, I wouldn't want to listen to myself for more than 30 minutes, and you already got to listen to me for 100 minutes every week. So I think from that, and again, it's more than a full movie. I've been talking more than a feature length film, which is odd to think about. But again, it's just at some point it's too much, right? And that's why I like YouTube, because you can pause me if you wanted to like take a break for 5-10 minutes, come back, you unpause me, I'm right there, right? No disruption to your learning as opposed to like Zoom or something like that. So that's kind of the method to my madness. I don't know if it's the perfect way to do things, but it's been working for me so far. So I'm going to kind of keep sticking with that for now. Honestly, if you want more class hours, and it may not affect you, but maybe future classes, talk to your people at the school and say, hey, we want more credit hours for this class. That's one way to get more time, more ability to fit more topics in, things like that. So if that's something you would like to see, then, certainly you can put that into your evals. Yeah, I think I like the straight through as well. It'd be kind of silly if I was like, okay, guys, take a 10-minute break and I'll come back. Like, I'm just gonna do it straight through. It just makes it easier. You guys get a nice 20-minute break instead of just 10. So anyway, so that I just wanted to give you my thoughts on that. I try to be candid with you all as much as possible, and kind of my thought process. But certainly, and one thing I want you to know too, because we're still early on in the semester, is feel free to reach out to me if you're like, I really wish you would do this, or I really feel like I'm not learning well because of this. Let me know early, even if it's anonymously, because I would like to address that, right? Because I think getting feedback earlier, it means I can make changes. I can course correct earlier. And two, the other thing I want to, and if you want to leave, you can. I'm just kind of rambling at this point. But the other thing too, I'd like to mention, yeah, exactly, the full movie. Yeah, by the end of this course, is like watching the extended cut Lord of the Rings like twice over or something. But the other thing too is that if you tell me something like, well, you're a bad teacher because X, Y, and Z. None of you guys say that, but if you were to say that, then I can contest that. I can be like, well, I don't think I am. I disagree with you. But if you say I'm not learning because of this, I can't object to that. You're telling me you're not learning. I need to find a way to make that happen. So please, Canvas or Outlook, it all comes to me regardless. So you can email me wherever. Again, if you want to make it anonymous, I don't care. But I'll have a frank conversation with you guys regardless. If you want to meet via Zoom, that's fine too. So I want to be open to you guys. Even though I'm not full time for Advent, I still treat you guys like full time students, and so I want to make sure you're getting your money's worth out of your education, because you guys are paying a lot of money to be here. So, but yeah, either way works. And yeah, so that's going to be it for me today. I don't see any questions on the board, but hopefully, and I'll check out the test. I'll get the stats, and we'll go from there. And I'll put an announcement out about that, and I'll get your stuff. You never got a reply from me? I thought I resend that to me, Vlad, and I will check that out. I apologize for that. I will sincerely give you an apology. I will yeah, sorry about that. Yeah, no problem. So yeah, just email me. I'll try to get to that. I apologize. Anyway, you guys have a great weekend. So someone actually put it. So I think people wanted more Kahoot. I honestly, like, I wish I had time to do that. Like, unfortunately, we only get 14 sessions or something, and there's just so much content that I have to fit in here that it's like, to do that, to like spend that extra hour, I'd have to like cut out like a whole section. So it's like, what do I cut out? Do I not talk about diabetes? I can't do that. Do I not talk about nephrology? Well, so there's so many critical things that I have to hit, that you guys are going to be expected to know for rotations and for the pants, that's why I'm unable to really do that extra time, unfortunately. And again, you guys I can only do so many hours because of university stuff. Like, you're getting only so many credit hours and all of that. So that's kind of the constraints that we're under, sort of the background stuff that goes on with a lot of that. I would love to spend even more time with you guys, but due to the university setting the things up the way they did, that's just the nature of the beast, unfortunately. However, I will have you know that all my videos are up on YouTube. You can go back and look at years ago stuff from really anything I've ever done, and if you find a Kahoot there, then I'm not gonna fault you for it. I'll say thanks for the view more than anything. But yeah, so otherwise, thank you guys for joining me today. I really appreciate it. I hope you all have a wonderful weekend, and I will see you next Friday.